much later by Joe.
Yes, shared screen, but previously it was coming okay, but not now.
On
There
Zoom,
is some
if there is a
network issue, I believe. There is some network issue that is coming some blurred.
Exactly.
No, it's not a network issue. While sharing, share optimize for video.
Hi, Dr. Ashok Shyam.
Hi. So try once with optimize for video and try once unclicking that and see. It will work.
Before making live, Ashok will give a countdown, then you start the webinar.
Nirmal.
Saman sir. Saman sir.
Yes, you are audible. Yes.
Saman sir, in the chat box, I am giving you the YouTube link.
Okay. Yes. Please do so.
Nirmal.
Then we can put it in the groups.
Yes.
Join Kalani?
I have already given the YouTube link.
Yeah, thank you. Thank you.
President Secretary को बनने को कहीं दिला बो फोन कर दो ची तमें कर दिया ओके हाँ
Can we check Dr. Venu's presentation again?
YouTube is already there. I will broadcast once you give me the green signal. Then will I broadcast for the viewers. It has not broadcast till now.
It is already being broadcast.
No, I have not broadcast from here. It has been broadcast from YouTube only. I am not broadcast from here.
On YouTube, it's visible?
YouTube is visible. YouTube is visible. YouTube I have already broadcasted from, but from Zoom I have not broadcasted yet.
No. It is already visible. See?
It is in YouTube, sir. YouTube, not from here. YouTube already.
So if somebody listening, yeah, it is being broadcast.
Please wait once Ashok makes his live on Ortho TV and IO TV. We will tell you. Then please start the webinar only.
Just within 30 seconds.
सुधांशु तमें जॉइन कर जा विकास सर को कह दिया आम जो वेबिनार अच्छी जॉइन कर समस्त जॉइन कर स्टार्ट हम हाँ जॉइन कर जा ओके
Mohammed sir, good evening.
Good evening. How are you?
How are you, sir?
Yeah, I'm fine.
After long.
Good evening. Good evening, everybody.
Good evening.
Hi,
Sir.
Venu.
Long back, yeah.
Hello, Sudhanshu. Chiniparcho.
Sudhanshu kahin?
When will you start?
You give me the green signal, I will make the broadcasting. It's already 8:02.
Sure.
Ashok, are we live?
Madhu is there and Sudhve, namaskar.
Namaskar. Later as
Hello. Hi, Ashok. How are you? Thank you.
So I'll give a countdown now.
Yeah, we all always take up this type of peculiar things, you know. We have
That's
all
good.
these lines of like this.
So, Dr. Ashok, you give me the countdown, right?
Yes, I'm just giving you a countdown.
Okay. Okay.
3, 2, we are live now.
Okay, we can continue and start, sir.
Please start.
Yes. So this is our second
Hi,
webinar.
Madhu.
This is our second webinar of OJOT in this season, and this will be on the topic of Charcot Foot. And so, this is what better way but to have a collaboration between the state chapter of our Odisha Orthopedic Association and the state chapter of Associations of Surgeons of India. So we decided on this collaboration, and I would request Dr. N.C. Mahapatro and Dr. and Kailash Mahapatro to kindly give a brief introduction about our speakers, our panel members, and then we can proceed.
I request Professor Kailash Mahapatra to start the introduction and introduce our speakers. Then only I'll go on.
Thank
Kailash,
you
sir.
very much, Nirmal, Saswat. It's a great pleasure and delight to be here today in this event, this session jointly organized by the Association of Orthopedics Association of Odisha and Association of Surgeons of India, Odisha State Chapter, with the Orthopedics Journal and Trauma, the members of that committee also. It's a unique opportunity, and I think all of us will be greatly benefited. We have picked up a very nice subject, the Charcot Foot reconstruction. And in this forum, we have two overseas speakers who are international authorities on the subject. They are extremely renowned and famed and acclaimed as the pioneers in reconstructive surgery in diabetic Charcot Foot all over the world. At the outset, I welcome everybody on behalf of my co-moderator, Dr. Nirmal, and very good evening to all of you. And to overseas faculties, a good afternoon, very good afternoon. And besides that, we have very renowned panelists, Professor Banabihari Misra, Head of the Department of Surgery, SC Medical College, Professor Avanikanta Misra, Head of the Department of Orthopedics, MKC Medical College, and Professor S.R. Patnaik, Professor and HOD Endocrinology and MKC Medical College. So we have a galaxy of faculties, speakers, and panel members who are going to give us a very good academic feast today evening. And we are discussing about a very common problem, which is all confronted by all of us in day-to-day practice, that is diabetic foot. And problems of diabetic foot, as you all know, are enormous. And this also perturbs us all in clinical practice as we face these problems every day. And not only that, the diabetic foot complications like a neuropathic infected foot, a vascular foot, gangrene and ischemia are repugnant, and Charcot foot are all challenging for management. And it is very pertinent at this time for all of us, these surgeons of Odisha and the surgeons and orthopedics friends of Odisha have joined together to collaborate on this platform, a very, very interesting topic of managing these very precarious complications of diabetes. As you know, the incidence of Charcot Foot has been increasing, which was a rare disease previously, but now it has been increasing in incidence and is posing a huge problem so far as the diagnosis is concerned, as well as the management is concerned. Many times it is missed, or there is a misdiagnosis. And besides that, also there is always a lack of understanding this problem amongst the clinicians, surgeons, orthopedicians general physicians, whosoever encounter this problem, because in our part of the country, there is filarial lymphangitis, cellulitis, osteomyelitis. These are the common problems which we encounter, and sometimes they are misdiagnosed, and if these cases get neglected and they land up with deformed, unstable foot, and finally gets ulcerated, infected, sepsis supervenes, and we lose many limbs like this. So to have a very clear understanding, we have we have planned like this. I'll just share my screen, a few slides which are the my slides are visible.
Yes, visible.
Okay. So Charcot neuropathic osteoarthropathy, Charcot Foot is a severe foot complication of diabetes in which there is considerable bone and joint destruction. And it was first described by John Martin, and then it was established by Jordan that diabetes also causes this same problem. It is also seen in other conditions like alcoholic neuropathy, syringomyelia, spina bifida, leprosy, congenital sensory neuropathy, familial amyloid neuropathy, and HIV-induced neuropathy also. Charcot neuroarthropathy is expected to rise as there is a global recognition of this condition, and there is also global increase in the prevalence of diabetes, which is definitely contributing to increased number of Charcot neuroarthropathy. A unilateral hard swollen red foot in a diabetic patient is diagnosed as Charcot foot unless proved otherwise. Exact mechanism of this condition is unclear. There are two theories which are proposed, like neurotraumatic and neurovascular, but there is a pro-inflammatory condition which exists, and there is localized inflammation, and the inflammatory markers are increased, like IL-1, IL-6, TNF-alpha, and there is overexpression of rank L. This overactivity leads to increased osteolytic activity, leading to bone resorption, bone destruction, and fragmentation, and joint dislocation. The classifications are the most earliest is Eichenholz's classification, and there is modification by Brodsky, and the recent classification of Sanders and Frickberg. There are 4 stages in Eichenholz's classification. Stage 0 is prodromal, followed by fragmentation, coalescence, and remodeling and reconstruction. In stage 0, there are signs of inflammation like red, hard, swollen foot. It is at this stage that the diagnosis is mostly missed, and there are some conditions which mimic, as I said, and very common in our part of the world is filaria, which is very common, and we miss them as thinking as cellulitis. Sometimes it is also missed as osteomyelitis, some arthritic conditions like gouty arthritis and rheumatoid arthritis, osteoarthritis like this. Also we miss here. Management will be discussed. Today we'll be discussing about surgical reconstruction. And stage 0 disease is the conservative management, but as the stage advances to stage 1, stage 2, stage 3, surgical management has become the gold standard, has been carried out in many centers in the world. And nowadays, under the multidisciplinary foot centers being promulgated by various societies, and so the patients are get benefited, and this sophisticated surgical procedures with highly technological instrumentation, we are able to achieve a stable and a plantigrade foot by which the patient can have a normal life, at least with restricted mobility. Thank you very much, friends. Now we'll move on to our guest faculties who will be, firstly, I'll call upon and invite Professor Venu, our overseas speaker from UK. Professor Venu is the son of the soil and from Hyderabad. We are very proud of you, Professor Venu. You have acclaimed so much of international fame in diabetic foot reconstruction. You are working as a consultant orthopedic surgeon at King's College Hospital, London. You are also honorary senior lecturer of King's College London, associate professor, Odense University Hospital and the University of Southern Denmark. You are a member of the Education Committee of British Orthopedics Foot and Ankle Society. And most importantly, and the recent one, is the president of the International Association of Diabetic Foot Surgeons. So he is controlling the entire globe so far as Charcot Foot management is concerned. Thank you, Professor Venu, for giving your time and valuable inputs, and we are eagerly waiting for your deliberations. Now over to you, Professor Venu. You can share
Thank you
your.
very much, Professor Kailash.
Please answer, sir. Please let us. Why don't you introduce Dr. Madhu also, so that before we introduce the faculty, then he can start his lecture.
Okay. We have also with us Professor Madhu, and he's also the son of the soil, and we are proud of you, Professor Madhu. Professor Madhu is a consultant orthopedic surgeon at Mid and South Essex University Hospital, Basildon, UK. He has special interest in foot and ankle surgery, particularly diabetic foot reconstruction and pediatric orthopedics and trauma orthopedics. So, Professor Madhu, we are also having you, and we are very eager to listen to you today also. Thank you very much.
Sir, before I introduce my other panel members, I can say Dr. Venu and Madhu, they are known to us for last maybe a decade, and they have visited our institution also and deliberated with our postgraduates. They are fantastic academicians. So we think today's seminar will be fruitful. Now let me introduce our other faculties. We have our few panelists. Professor Abanikant Misra, he is one of the senior most professors in Odisha. He is now currently a professor and HOD Department of Orthopedics, MKCG Medical College, Barampur. And our next panelist is Professor S.R. Patnaik. He is the Professor HOD of Endocrinology, interest in this diabetic foot management also. He is the President of Odisha Endocrine Society. And we have also Professor Dr. Banabihari Misra. He's the professor and head of the Department of Surgery now in SC Medical College, Cuttack. And he has a long experience as professor and as academician. And he has many achievements to but will not continue all those things. And because it will take time, we have a few other very important personalities, Dr. Samsul Hoda and Dr. Ashok Sam. They are the new generation IT specialists of Indian Orthopedic Association, and they have revolutionized these webinars and non-virtual teaching programs in India by Ortho TV and IOA TV. So welcome you all. Now, before requesting Madhu to start his lecture, I also welcome the President and Secretary of Odisha Orthopedic Association and Dr. Professor Basant Kumar Mehra and Dr. D.K. Samantara, and also Secretary of ASI Odisha, Dr. Sudhanshu Shekhar Sutar, and their Chairman, Dr. Vikas Pota, and also Sirsendu and Saswat, all of them. I think that's enough for introduction because we are waiting to hear Venu's lecture. Venu, you can share and start your lecture.
Good evening, everyone. I would like to thank my friend Professor Nirmal, Dr. Kailash, Dr. Dilip Kumar, and all the colleagues from the Odisha Orthopedic Association and Association of Surgeons of India from the Odisha State Chapter. I'm Professor Venu Kawathapu. I'm an orthopedic consultant, and I'm going to share our experience in the surgical reconstruction of Charcot Foot. Greetings from London and from King's College Hospital. Charcot neuroarthropathy was actually described a long time ago, in 1868, by Jean-Martin Charcot in patients with tabes dorsalis. But its association with diabetes was established much later by Jordan in 1936. Even then, the pathophysiology of Charcot is still not very clear. There are multiple theories, but it's not very completely understood. But we know that this is associated with peripheral neuropathy. It is known to decrease the life expectancy of those individuals that develop by about 14 years. And the lower extremity amputation rate is quite significant. We at King's College Hospital, we are the first ones to establish the multidisciplinary diabetic foot clinic about 40 years ago. And a large practice of mine is in dealing with Charcot foot reconstructions. And I would like to share our experience. By and large, a patient with an acute Charcot presents with a sudden, unexplained, painless, red, warm, and swollen foot with no significant history of trauma. The patient may say that I woke up this morning and cannot get my foot inside my shoe, or I was walking along and I suddenly heard a crack and my foot started swelling up. And Professor Michael Edmonds, the diabetologist who has studied extensively, has written a few books about this. When you examine, you see, a warm, swollen red foot and ankle, and there can be a deformity if the presentation is late, and there can even be crepitus or in advanced presentations as bag of bones. It is known that the Charcot in acute phase results in raised temperature locally, and it is very useful to measure the temperature difference using any device and compare with the opposite normal foot. And if it's more than 2 degrees, that is considered as significant. So in an acute Charcot, some trivial primary injury usually triggers this uncontrolled inflammation due to lack of neurological control from peripheral neuropathy. And the patient doesn't have normal sensation due to neuropathy, so doesn't experience any pain. So patient continues to walk, causing secondary trauma, and that establishes the acute, which is active Charcot. But if offloaded adequately, it develops into inactive status, and eventually with continued offloading, the Charcot heals. But during this process, quite often, most of the feet develop deformities, and that deformity through healed Charcot becomes permanent. So I would like to reemphasize that a red, warm, swollen foot should be considered as an acute Charcot until proved otherwise. It can also be due to other conditions such as cellulitis, infection, but by and large, if the skin is intact, it is almost always an acute Charcot. So you should ask the patient to offload through non-weight bearing. And if you don't deal with such presentations, you should refer the patient to the regional center immediately. Plain radiographs are extremely helpful. They also help us identify the staging of the acute Charcot. During the first stage, you see a lot of bone fragmentation, and later the fragmented bones can coalesce and finally consolidate into a deformed rigid Charcot. That is stage 3. And we know that pre-radiographic stage exists where the clinical presentation of an acute Charcot, but with normal radiographs. But if you do advanced imaging such as an MRI or CT SPECT, you can clearly see those changes, and that is given a separate staging, the pre-radiographic stage, stage 0. And it is very helpful if we diagnose these conditions in stage 0 or at least in stage 1. We're not going to go through the detailed non-operative treatment. We'll focus on the surgical treatment, but by and large, an acute Charcot should be managed with offloading, ideally in a total contact cast. If you want to see the technique of total contact casting, you can see this YouTube video. but the steps are that you apply well-conformed cast, including the toes, and then ideally in an acute Charcot, the patient is recommended to mobilize non-weight bearing, but some form of weight bearing is allowed in early stages. In addition to the total contact cast, which is considered as a gold standard, one can consider a bivalve total contact cast, or a clamshell crow walker, or even the commercially available braces if the foot shape is normal. So an acute Charcot often responds very well to immediate offloading, and through different stages reaches the consolidation phase. And in many patients, the deformity may not be significant enough so that they can walk in surgical shoes quite well. But if the deformity is significant, particularly if the plantar bone prominence, quite often exostectomy becomes necessary if the patient develops ulceration or impending ulceration. But if the deformity is quite marked, reconstruction becomes necessary. So this is the standard progressive phase of an acute Charcot progressing to a chronic deformed Charcot. But however, some of these acute Charcot presentations continue with instability and progressive deformity despite your good offloading technique. And those can develop this foot at risk situation where the offloading measures do not work, but in front of our eyes, the foot continues to develop a limb-threatening situation. And this one example in a 62-year-old type 1 with peripheral neuropathy, no significant trauma, developed this kind of osseous damage, clearly an acute Charcot, and you can see the medial cuneiform has extruded. And with that degree of extrusion, you can imagine that if the patient continues to mobilize in regular shoes, it results in skin necrosis, ulceration, osteomyelitis, and so on. So this is an acute Charcot with foot at risk presentation. So that requires an immediate surgical intervention. We don't wait until this goes into stage 2 or stage 3. So aggressive debridement, excise all of that infected bone, and on this occasion, we had to do this as a 2-stage procedure because the infection was very aggressive and active, and the first stage involved excision of the exposed and osteomyelitic medial cuneiform and the local debridement. And then once the the infection status we are happy with, then went back in on this occasion about 10 days time and internal fixation. So here we are actually doing this surgery while the Charcot is very active. So the foot soft tissue swelling hasn't really completely gone. But because the foot is at risk, we have to do this way. So in this situation, we may not be able to achieve wound closure. The options are they do local flap, but this patient, as it with many patients, the vascular status doesn't allow free flaps. So VAC dressing is beautiful. It works very well for most patients. I was planning to do skin graft, and I didn't have to do. So we achieved good skin closure. So the patient was able to commence full weight bearing at 5 months' time. Another example of an acute hindfoot Charcot, this patient came from abroad, and you can see the leg was immobilized in a cast, and the cast shape is quite different to the leg shape, and this patient with multiple comorbidities and real limb at risk situation. So such presentations need to be aggressively managed. The medial malleolus is exposed through the wound. So this also requires as a 2-stage procedure. During the first stage, you excise all of that exposed and potentially infected and clearly infected bones. Here, the medial malleolus had to be excised. You prepare, do the bone cuts and correct the deformity, and temporary stabilization with wires, and give intravenous antibiotics and local antibiotic-eluting material, which I will describe in more detail towards the end of this presentation. And then you proceed with definitive fixation. Here, the subtalar joint was also prepared, and a hindfoot nail on this occasion provided predictable bone fusion, deformity correction, and the patient was able to commence full weight bearing. So in such type of acute limb at risk presentations, it is good to surgically intervene early. But most Charcot foot deformed presentations come as chronic or inactive deformities with our midfoot or the hind foot with such significant deformities without adequate offloading. They develop ulceration, infection, osteomyelitis, and then risk of limb loss. The problem with limb loss in people with Charcot diabetes is that the mortality following a below-knee amputation or major amputation in people with diabetes is extremely high. And many people are not aware of that. It is much higher than most common cancers. About 50 to 70% die within 5 years. In fact, the most recent studies reveal that 80% 5-year mortality in people with diabetes. So it is really important that we achieve functional limb salvage so that the patient remains ambulatory status. So we went through the algorithm. If the deformity is localized, minor with bone extrusion, as you can see in this particular example, chronic repeated ulceration with repeated infective episodes with that exostosis, and that type of presentation may be difficult for continued offloading, so surgical intervention becomes necessary. Here, the calcaneal pitch is also abnormal. There are significant abnormalities in the midfoot and forefoot mechanics, so that needs to be corrected as well. So aggressive ulcer debridement of all of that infected material down to the bone, and the bone exostectomy, remove all of that bone. But that is not sufficient here because the Achilles tendon is very tight, causing abnormal calcaneal pitch, and you will hear a lot more about this from the in the next talk. So you can clearly see in this picture the calcaneal pitch has improved. The patient has got plantigrade foot, a large soft tissue defect created from exostectomy and ulcer excision with VAC dressing healed completely. So, and the patient was able to commence weight bearing at about 5-month mark. Here, a midfoot reconstruction would be even better, but the patient was not keen. So, whereas major deformities due to Charcot, either the midfoot or hindfoot, are infected or non-infected, they come in so many different presentations. The key feature here in this particular treatment is to achieve functional limb salvage, not just keeping the foot, but it has to be functional so that the patient can maintain mobility, the foot shape can improve so that it can be shoeable, so that you can prevent ulceration, and ulceration, the cascade of events resulting in limb loss. So that is achieved through a reconstruction procedure. But historically, Charcot foot reconstruction wasn't considered routinely because of various challenges. The bone stock is very poor, bone healing potential is very poor, and they come with ulcerations, problems with skin coverage. Internal fixation, the commonest fixation technique we use, is known to fail, and external fixation is not tolerated well in this group of patients. Certainly in the UK, my patients don't like external fixation, and they don't keep the fixator for long enough to achieve the goal of permanent deformity correction bone fusion. So traditionally, these patients were offered a below-knee amputation. We know that it is not a favorable outcome through below-knee amputation. And we have recently done a systematic review, and it's interesting to see that internal fixation, which is in blue, is becoming more common technique of Charcot foot reconstruction. And there are specific principles of this fixation. If we share our experience, earlier experience through the midfoot reconstruction technique. So a standard midfoot Charcot that was managed in those days about 17 or 18 years ago through segmental fixation technique, as we do for degenerative deformity correction procedures. But in Charcot, that doesn't work because the bone doesn't have good healing ability, and the soft tissue imbalance is quite marked. The deformity simply returns. So the routine segmental fixation doesn't work. It has to be a long segment, rigid fixation with optimal bone opposition. That is the mantra we use for Charcot foot reconstructions fixation techniques. In this example of very simple midfoot Charcot with rocker bottom deformity, and before the patient had Charcot, he had normal foot shape. And here we do, plantar and medial based wedge resection to correct the deformity, to align the first metatarsal to the talus, and again fix with rigid fixation, on this occasion using locking plates of the medial and lateral column. And this was done almost 10 years ago, and the patient has remained ambulatory since then, 11 years now. So another example of infected midfoot Charcot. This is slightly more complex deformity, and this particular deformity is called subluxation type. And here, there is plantar ulcer as well, but it was not actually infected. So we did everything in one go. It's critical that you identify and map the dorsalis pedis and posterior tibial arteries when you do midfoot reconstructions by doing Doppler, excise the ulcer, redrape the foot, and again do the deformity correction through osteotomies, and fix using the long segment rigid fixation technique. Nowadays, most of this is achieved through beams, and you can see the medial and lateral column beams used on this example. And this also resulted in very predictable deformity correction. As soon as you achieve deformity correction, the ulcer heals, and it stays healed, and then the patient has been infection-free. When it comes to hindfoot, the fixation principles are exactly the same, and we have described those in this particular paper. So this example of hindfoot plus midfoot reconstruction with previous recurrent infections from the deformity, and patient has been load bearing along the lateral border of the midfoot. Here, again, the same principles: prepare the ankle and subtalar joints, correct the tightness of Achilles tendon, plus long segment rigid fixation of the hindfoot and the midfoot through the first medial column correction. And here we use the antibiotic loaded local eluting material as well to achieve infection eradication. So a different fixation principle in this case example of very flail hindfoot but with severe bone loss. So on this occasion, it's impossible to achieve rigid fixation of the hindfoot due to the amount of bone loss, particularly in the rotational alignment. So for that, we like to extend the medial column plate onto distal tibia. That provides rotational rigidity of the construct as well, and that seemed to work amazingly well in these in such presentations. Even more example of more and rigid severe deformity of the hindfoot plus midfoot with recurrent infections, and you can clearly see on this radiographs very severe deformity. And here there was SFA occlusion as well. That has to be addressed first. We always correct the vascular problem first before proceeding with the reconstruction. We tend to do the reconstruction deformity correction about 4 to 6 weeks following the vascular procedure. Very extended lateral approach, correct the ankle deformity first, and then subtalar, then join them, all of them line up and achieve compressive rigid fixation, and the residual midfoot deformity is corrected through the same principles, using the same principles I described earlier. And this patient has been ambulatory for a long time. Clearly, most importantly, infection hasn't returned. So we have, published our outcomes through various publications, and predominantly you have seen non-actively infected Charcot foot reconstructions, but there are occasions where actively infected Charcot feet present for functional limb salvage, as in this example of pouring pus through failed previous multiple surgery. Such presentations require very methodical two-stage reconstruction. In the first stage, here, all the infected material was excised, the metalwork was removed, and you use the standard principles of aggressive surgical debridement and physical removal of all the infected antibiotic eluting material used to achieve local infection eradication. And the choice of the antibiotic depends on bone biopsies and deep tissue specimen cultures. Once you achieve infection eradication, through this aggressive debridement and correct the deformity at the same time and provide stability through these threaded wires, you tend to see quite rapid and predictable soft tissue healing with simple measures such as vac dressing. And once we are happy that the infection has been eradicated, generally, after 6 weeks, you monitor the CRP that comes down and stays down, and you make a surgical plan on how to reconstruct on this occasion using hindfoot nail plus midfoot plates and beams. And local antibiotic-eluting material was injected into the gaps, again to remove any residual infection, potential infection. And it's really critical that we achieve long segment rigid fixation. Otherwise, the bone healing response is poor or unpredictable. And this patient also had very successful outcome. A 26 patient series has just been accepted for publication, 2-stage reconstructions of Charcot Foot in the BJJ. So that will come out maybe in a few weeks' time. So just to reemphasize, these require very proactive vascular management as well. And we have described about the targeted infection control and advanced wound care. And most of our patients require vac dressing only, and most of them are not suitable for a complex local flaps. But the critical component, what we learned, is this durable fixation principle, and it has to be a patient-centered, multidisciplinary approach. And in our unit, that team is led by the diabetologist, Professor Edmonds, and with support from the surgeons. So with that, I would like to thank you for your attention, and those who are interested in learning more about diabetic foot surgery and Charcot foot reconstructions and the multidisciplinary care, I would like to invite you to attend our Charcot meeting in September, and you can join this meeting virtually or physically. Perhaps physically is for local delegates in the UK. Thank you very much for your attention, and I'm happy to take any questions.
Thank you, Dr. Venu. Sorry about your presentation quality because of your traveling, you told. So, but anyway, it was very informative. And I have seen your center, how fantastic work you people are doing in King's College. Maybe sometimes we'll have more opportunity to listen to you and contact you. So all along for last few years, you have been advising us how to manage our Charcot Foots, and maybe even I have done 3-4 surgery with your guidance to success. Thank you. Next, I invite Dr. Madhu to start his talk on external fixation of Charcot joints. And we'll take the questions after he finishes the lectures. Madhu, please share your screen.
Okay, can you hear me?
Yes, audible.
Okay, and can you see my slides?
Sure. Okay, carry on.
Okay, that's great. Okay, thank you very much, Dr. Nirmal, and it's a pleasure to be part of this meeting. So here, first of all, my name is Madhu Tiruvilla, as you've been introduced. I'm going to take a completely different talk to what Professor Venu has talked. Here, I've been working with diabetes for the last 3 to 4 years. I do reconstruction, but my talk today is going to talk about the pre-operative things which we can do to avoid for the development of the deformity, and also how we can prevent things worsening. So we're going to talk about the soft tissue balancing and other preventive measures. So we know that the diabetes is associated with more than 60% of the amputation, and one of the precursors of an amputation in a diabetic patient is the ulceration. And the incidence is around 19 to 34%, depending upon which publication you look at. So in this talk, we're going to talk about how does a midfoot Charcot deformity develop, what are the deforming forces that works on it, and what early intervention we can do to prevent progression of the deformity, and how do you quantify if there's a deformity and how it's progressing and when to act? So you know that this is a typical midfoot Charcot deformity. It has a deformity both on the coronal plane and also on the sagittal plane. So if you look at the sagittal plane, the first thing you notice is there is a significant hindfoot equinus. So the red line describes the equinus, and the whole complex of the hindfoot is just tilted downwards. And the most deforming force is due to tightness of the calf and tendon Achilles, which becomes tight. So, and then as the patient walks, there's a ground reaction force on the forefoot, which causes a counterbalance lever, and as a result, the midfoot breaks. And as the deformity progresses, as the bones start to protrude the skin, and the people develop ulceration and the bony prominences. In the coronal plane, when the deformity starts at the midfoot, the rest of the midfoot start to go onto one side. Most commonly, it goes to abduction due to the intact peroneal brevis pushing on the fifth metatarsal and causing the fifth toe to abduct. Now, it can be a simple two-plane deformity of abduction, or if the peroneal tertius is acting, it can be a pronation deformity as well. Sometimes, very rarely, you can see an adduction deformity, which is very rare. Now, this is due to the tightness of tibialis anterior and tibialis posterior tendons. We all know that the deformity typically starts on the midfoot, the medial column, and then slowly involve the middle column and then the lateral column. The coronal plane deformity, although the bony prominences you can see, and often this can cause bony bump on the medial side, which can be a problem with the shoe wear, but often, very rarely, produces ulceration on the medial side of the foot. So we're worried about the plantar surface of the foot. So question is, how does this happen? And how do we quantify it? And can we do something to stop it? So question is, how does this happen? We all know that the patient with the diabetic, long-term diabetes, mostly with uncontrolled diabetes, they start to have a peripheral neuropathy. Now that can be a sensory neuropathy, motor neuropathy, autonomic neuropathy, and a combination of it. And the motor neuropathy is the most critical bit. It starts distally, affecting the lumbricals of the toes first. That's why they all have a claw toe deformity, and then progresses proximally to involve the major muscles. And one of the common muscles is the calf muscle, which is the gastrocsoleus complex, and tendon Achilles. So there's various studies has been done, and which shows that the effect of the neuropathy on the complex and the large muscles is by producing a contraction of the muscles. So the gastrocsoleus muscles contracts, and then there are electronic microscopic changes seen in the tendon Achilles collagen fibers with the glycosylation, etc., that causes a shortening of the tendon fibers as well. So you got a contracted muscle and a shortened muscle, which produces a quite significant hindfoot equinus. As a result, you got a significant equinus deformity. Now, how do you quantify it? So looking at the literature again, various people have suggested various X-ray findings, but that we need a standard X-ray. These are the standard X-ray what we do in our department, with a standard AP of the foot and the lateral of the foot and ankle shown on the single plane radiograph. So the first one you talk about the calcaneal pitch. Calcaneal pitch describes the hindfoot equinus. Normal between 18 to 20. It is an angle between the inferior surface of the calcaneum to the weight-bearing axis of the lateral column, which is from the calcaneum to the fifth metatarsal. And on the lateral view, we also look at the what you call a lateral Maris line or angle, which is a straight line across the first metatarsal to the talar, body, and neck. And if there's a break in that Maris line, we can say that the middle column is broken. But the most important thing is something called cuboid height. It is the height of the cuboid in relation to the weight-bearing axis. So the weight-bearing axis from the calcaneum to the fifth metatarsal, and the perpendicular line from that line to the inferior part of the cuboid is called cuboid height. So as I mentioned, as the deformity progresses from the medial to lateral side, the medial column, when it breaks, it causes deformity, but it does not cause ulceration. But when the lateral column is involved and when the cuboid drops down, that causes ulceration. So there is a critical point which we'll describe in future. So we talk about the line A, which is the Maris line, line C, which is the cuboid height. And on the AP view, we talk about dorsal meris line. Now, this is only an importance when we're reconstructing the foot, because obviously this does not cause ulceration itself. So significance, as I mentioned, if the midfoot collapses and if the cuboid drops down below this line, that can cause pressure and a classic rocket bottom deformity and ulceration on the plantar lateral side of the foot. So we noticed that the combination of the equinus deformity from the tightness of the calf muscle and tendo Achilles causes equinus foot, equinus hindfoot, and equinus hindfoot with the counterbalance at the ground reaction force of the forefoot causes failure of the osseous ligament structures in the midfoot, resulting in midfoot break. So again, looking at the literature, various people have talked about tendo Achilles lengthening in patient with midfoot Charcot. Now, most of these procedures have been described in theater, but by itself, the tendo Achilles lengthening is reduced to is known to improve the dorsiflexion, reduces the peak plantar pressures of the forefoot and also the midfoot, and improves the overall walking ability. So the people in the literature, if you look at it, they described about tendo Achilles lengthening and total contact cast, known to reduce the peak plantar pressure and ulceration more in the forefoot than at the midfoot level. So we've been doing tendo Achilles lengthening, but not in theater, but in the clinic. So we've been practicing tendo Achilles lengthening in the clinic since 2018. All these procedures carried under local anesthetic. We included all the patients who present to us with a midfoot Charcot deformity, but excluded patients who have obvious ulceration and osteomyelitis because they need surgical intervention, or when they have a combined hindfoot and midfoot Charcot deformity. So the procedures are done by 2 orthopedic surgeons in the department and 1 medical endocrinologist. We got the approval from the hospital governance team for the procedure. And as I mentioned, we use for midfoot Charcot, but also we use for forefoot ulcers. I'll talk that in a minute. And also in a patient who are quite thickened plantar callosities in the forefoot. So the procedure is performed after a written consent, supine position. Some people, one of the surgeons do prone position, it doesn't matter, but we usually use a Hoke technique, which is a hemisection of the tendo Achilles. We do 1 cut on the middle side, 1 cut on the lateral side, a 3rd cut if the correction is not fully completed. But often we just do only 2 cuts. But the most important thing is we avoid pushing the whole foot into dorsiflexion. We just do the simple cuts and apply a total contact cast straight away and let the patient walk. And when the patient walks, the tendo Achilles lengthens to the optimal position and stabilizes accordingly. So we don't force the foot into dorsiflexion. So our post-procedure protocol is walking plaster cast for 6 weeks time. We give a thromboprophylaxis to prevent risk of deep venous thrombosis. And we do a weight-bearing radiographs at 6 weeks time and compare the angles what we just described. After 6 weeks, they come out with the plaster cast and they go into walking boot. So we noticed an improvement in the calcaneal pitch in patients before and after tendo Achilles lengthening. So this is a pre-procedure and this is a post-procedure calcaneal pitch. So now we want to quantify how what we're doing, is it effective in patients with diabetes? So we looked at the present classification systems. They are very good. They describe where the problem is, describe in anatomy and how it's progressing. But what it does not do is describe what can be done to treat it on a particular level. So we sat around and designed a new classification system, looking at the clinical and radiological findings, and then correlated with the treatment plan, what we can offer. So we described a new classification system. We designed a classification system from stage Z1 to stage 4. Stage 1 is similar to Eichenholz's stage 0. Stage 2, which divides stage 2A and 2B, is a stage of pre-ulceration. But once there is ulceration, stage 3, and when there is a combined deformity of hindfoot and midfoot, is stage 4. So this is stage 1 deformity, where it's similar to Eichenholz stage 0. Often the person comes to us with a hot swollen foot, as Prof. Vegni just described. They have no previous problem, just diabetes, and they woke up with a hot, painful, swollen foot. There is a temperature difference, and the X-ray shows no changes on any of the X-ray parameters. So treatment we offer is tendo-Achilles lengthening straight away in the clinic, followed by weight-bearing total contact cast, as I just described. In stage 2A, where there is a break in the midfoot, as we just seen here, but the cuboid height is well above, so it's a positive cuboid height. Again, most commonly a patient present at this stage with an acute Charcot foot, and again the treatment will be tendo-Achilles lengthening followed by total contact cast. Once the deformity has stabilized and we notice on the follow-up X-ray there is no progression, then we worry about what we do with the residual deformity. Either we refer to them for a customized orthotics or a shoe wear, or if the bony prominence is too bad, then we excise the bony prominence. But we follow it up to make sure that the deformity is not progressing. So stage 2B, which is an extension of what we've seen in stage 2A, but here the cuboid has dropped below the line of the weight bearing. So it's a negative cuboid height. So the risk of that one is because it's pushing on the skin, hence the risk of ulceration is very high. But they haven't got the ulcer yet, but the risk is high. At this stage, we do again tendo-Achilles lengthening with total contact cast, and then see what happens. Most of the time, the disease stabilizes. If it stabilizes, we just excise the bony lump or try to accommodate in the specialized insoles. But if they progress on the X-ray and the skin is at risk, then we go with a single stage reconstruction, as just Prof. Vedu has described. So stage 3 is stage of ulceration. Now it's too far and the skin has broken down and there is osteomyelitis. At this stage, tendo-Achilles lengthening and other non-operative treatment are difficult. However, we notice that there are two types of ulcers are seen, depend upon what stage they present. It could be a simple superficial one or deep one. But the critical point of Mary's angle between the two lines of more than 27 degrees is considered too critical that it can be salvaged with non-operative treatment. So we notice that the 3A of stage 3 is a superficial ulcer with no evidence of osteomyelitis on the MR scan. A 3B would be an ulcer with osteomyelitis. So in patients with 3A, we still try to save them with the tendo-Achilles lengthening with total contact cast and see what happens. But however, if the deformity is progressing or if the ulcer is not healing, then we go with a two-stage reconstruction as Prof. Vedu described. But in 3B, we directly go for two-stage reconstruction. So stage 4 is a combined deformity of the midfoot and hindfoot, where there is either complete involvement of the ankle or subtalar joint, or the midfoot has an ulcer or without ulcer. So it's a combined deformity. And again, as Prof. Vedu described, we do a combined correction of the hindfoot and also of the midfoot, as the X-ray shows. So we start with the hindfoot and then we go with the midfoot fixation. It depends upon the ulcer. If there's an ulcer or osteomyelitis, we do in 2 stages. So what's our result? From 2018 onwards, for midfoot Charcot, we followed them a minimum for 1 year. So we've been doing from 2018 and we got a lot of patients, but we collected the first few, we completed at least 1 year follow-up. So we done in 33 feet and these are the distribution of the patient. And as you can see, most patients present with a 2A condition. So these are the results after tendo-Achilles lengthening. That's very important. In stage 1, which is Eichenholz stage 0, if you've got an acute Charcot foot and if you do a tendo-Achilles lengthening and a weight-bearing total contact cast, 100% of the people recover and do not progress. Although we do follow-up X-ray up to 1 year, and none of them progressed enough that we need to do anything further in the future. In stage 2A, 8,600 people, they recovered. And only 2 of the people, they progressed to stage 2B disease. Now that's because of the other factors, but at least 86% of people, we avoided progressing on to the next stage. In stage 2B, where the deformity is so significant, it started pushing on the skin, okay, we stopped ulceration in the people by 100%. None of the people have progressed to needing a ulcer treatment. They needed an exostectomy at most, but that's about it. But in stage 3A, when they already got an ulcer which is superficial, we still managed to save them by 75%, and only one of the stage 3A, but it's only 4 feet, so it's not large numbers, where they went on to needing a two-stage reconstruction. Again, if you look at the calcaneal pitch, it's improved by an average of 6 degrees. Earlier we see, the more calcaneal pitch improvement we see. But more importantly, in some patients, especially in 2B, when the disease is already progressed, if you do tender Achilles lengthening, the disease process improves. So stage 2B becomes stage 2A in 3 feet, we see in that. So again, we want to check whether the classification system what you described, is it a valid one? So we given to 12 people, 3 or 4 orthopedic consultants, radiologists, podiatrists who work with us, a medical consultant, and a vascular consultant, because these are the part of our MDT. So I've given 10 slides at 2 settings and asked them to grade them. And these are our results based on the grading. So as you can see, both the inter-observer and intra-observer agreement is quite good and is excellent. So this has been published in the May Journal of the JCOT. Now, progressing the same thing about tender Achilles lengthening, what is started with 4-foot ulcers, then we sort of extend to mid-foot ulcers. So we've been doing for 4-foot ulcers from 2018 onwards, and so far we've done, I think, around 200 patients who have 4-foot ulcers and who at least have completed 6 months of follow-up. As you can see, with the 4-foot ulcer, we do a procedure, pre-procedure, 2 weeks and 6 weeks, the ulcer has healed. So this is when I did the audit, 96 patients, 109 feet, minimum 6 months follow-up. And earlier during our learning curve, we had a complete transaction of the tendon in 3 patients. That's the reason when I said we should not do a forceful dorsiflexion of the foot. So in 4-foot ulcer, just by doing tender Achilles lengthening, we avoided going back to theater and achieved full ulcer healing in 96% of the people. And also dorsiflexion improved, obviously. So in summary, plantar 4-foot ulceration is a very critical negative factor for development of osteomyelitis and thereafter amputation in diabetic patient. Ulceration results in amputation. Hence, whatever we have to do it early to prevent that ulceration. As the Prof. Venu mentioned, the 5-year mortality after amputation is around 80% plus. Therefore, early recognition and identification of potentially modifying factor is very important to prevent amputation. And tight calf muscles, which is a most dynamic deforming force, has to be dealt with whenever the patient is seen early on. So percutaneous tender Achilles lengthening in outpatient setting is very safe and very effective in utilizing this deforming force. Hence, I strongly recommend early tender Achilles lengthening in all the Charcot patients you see in the clinic. Thank you.
Well, thank you, Dr. Madhu. Please stay back for questions, Ajay. So before we go for questions, I will ask you some expert, our panels, some expert opinions. Maybe I'll request Professor S.R. Patnaik to tell about the medical management and pathogenesis of these Charcot Foots, diabetic Charcot Foots especially. And that is most important, I think, along with the management of this orthopedic management of Charcot Foots.
Thank you, Dr. Ma. Now, joint destruction is only part of the story. The mortality is also 3 times higher in diabetic Charcot joint disease.
My God.
And as Dr. Venu said, it gets even more magnified in patients who undergo surgeries. So we have to take a holistic approach on this issue. We have to treat the joint. There is no doubt about it. But we have to also treat the diabetes and neuropathy as well. The surgical management has been comprehensively discussed. I shall limit myself to some points regarding medical management. In the medical management, the first management concerning the bones and joints. Do we have any treatment modality for that? Very few. You know, if you go by pathogenesis, the rankle is the culprit. The rankle, which gets generated by different cytokines, activates osteoclasts. And these osteoclasts are unusually more active and they produce the bone damage. So what about anti-resorptive medications, which will tame the osteoclasts? We have bisphosphonates, calcitonins, and denosumab. There are many trials regarding with all these medications, but the treatment is not very satisfactory. There are plus minus benefits with these agents. So if you want to go ahead, you can go for try with these agents. But one thing, before you go for bisphosphonates, first correct if there is any vitamin D deficiency. Vitamin D deficiency can produce osteopenia. At the same time, if bisphosphonates are used in this situation, there may be calcium metabolism disturbances. Now, since we don't have much medication in this regard, we have to limit ourselves for the management of diabetes and neuropathy, which is very important. Unless the diabetes is managed properly, all your efforts will go in vain. Now, how to manage diabetes? In this situation, I will suggest only one agent, and that is insulin. Please don't try with other oral drugs. Insulin is the only treatment in this situation. And if the diabetes is properly controlled, our management issues will be easier. Here, I would like to mention about one anti-diabetic drug. These are known as gliflozins. Why I am mentioning it? These drugs are recently introduced. In the last 5-6 years, these drugs are being used very widely because this is the only group of anti-diabetic agents which can help in heart failure and nephropathy. These drugs are versatile with lots of pleiotropic effects. Hence, many diabetologists are fond of using these medications. But these medications, some of these medications like canagliflozin results in increased risk of amputation. So if your patient is under oral drugs, please see what drugs the patient is taking. Similarly, if the patient is taking steroids or some other immune suppressive agents, please take note of that. Blood sugar, proper blood sugar control will go a long way in managing our patients. Besides this, we have to take care of obesity also. Obesity is a risk factor for Charcot disease. Hypertension needs also attention. For neuropathy, we don't have much drugs. The aldose reductase inhibitors which are introduced were proved to be futile. So we have to depend upon vitamins and nutraceuticals like methylcobalamin and alpha lipoic acid. Thank you.
So, thank you, Professor Patnaik. I have heard about the age. What is this advanced glyco, role of advanced glyco semic products, end products in formation of this diabetic food?
I could not hear it properly. Can you please repeat?
It is advanced glycosemic
Advanced
end products.
glycosylation end products. What happens now when proteins, body proteins, which can be anything, any protein, whether it can be hemoglobin or whether it can be a collagen, whether it is a muscle protein, or whether even a DNA, RNA, now any protein which is exposed to high blood sugar levels, this undergoes structural changes. And these structural changes compromises with their function and structure. So this is the reason why, for example, Dr. Madhu was telling about so much about Achilles tendon length. But why Achilles tendons get shortened in the first place? Who shortens it? The mechanical problems of one reason is this glycosylation of these collagens. That's the possibility of the tendon shortening in Achilles tendon in diabetes.
Okay, thank you, Professor Patnaik. I'll ask Banu sir one question before others and Abani sir, and then ask questions to Dr. Benu and Madhu. Banu sir, I read somewhere that those foods, Charcot foods, having more circulation are more prone for diabetic Charcot foot than having less circulation. What is your take on that?
Thank you, Nirmal. Good evening to all the dignitaries and the audience. I think Nirmal has chosen a wrong person in the right subject. Exactly. I cannot answer to your question. But I can tell a summary of the Charcot foot or the Charcot joint in my experience over several years, being a faculty with Professor K.C. Mahapatra and as a good student of him during his seminars on diabetic foot. And my personal experience, since we are dealing with the most of the diabetic foot at the first instance in the surgical OPD. My experience is that whatever patients they have presented into the OPD as abscess, ulcers, cellulitis, and many times gangrene and septicemia. But I have seen that those patients who have presented with cellulitis, has undergone minor amputation, they are so careful in life, they have never suffered from a Charcot foot. Who have suffered, those who have small ulcer has healed, they have not been followed up properly, they have suffered from foot. Charcot foot, when they come to us, we refer to the orthopedic surgeon or to the diabetic foot surgeons. Only my feeling is that it is because of the illiteracy of the patients, ignorance of the patient, and lack of awareness about the future complications of the diabetic ulcer or the diabetic cellulitis. That is why I always advise that there must be. This is almost a preventable disease, and this prevention can be done only by care of the control of the diabetes with the wise help of the and advice of Sudhiranjan. And this should be properly taught how to take care of the foot, not only care of the diabetes, and they must be educated with pictorial knowledge about the progression of the disease, including the vascularity also. What I feel, your question was mainly on vascularity. I think impaired vascularity, impaired neuropathy, and obesity, along with the lack of control of diabetes, or the smoking, alcohol, all are additive factors to jeopardize the vascularity, to increase the neuropathy, and the patient might land in a Charcot foot. Thank you very much.
Thank you, sir. Yes, Professor Patnaik.
Here, I would like to add one point while I agree fully with Dr. Misra. Now, one thing what happens in diabetes, now this becomes this because of neuropathy, there occurs alteration of vascular reflex. Okay, so that's why the blood supply to the foot gets augmented, and there occurs arteriovenous shunts. Hence, blood supply to the bones gets increased. More blood supply to the bones, more of cytokines, and more of mononuclear cells leads to more of osteoclast activation and more of osteolysis. Now, what happens in this? Now, why I'm telling these things? Because, neuropathy is a very common problem in diabetes. But Charcot's neuropathy is very rare. Why that is so? Hardly how many percentage of patients get Charcot's disease? Different literature says 2 to 10%, maybe less. But neuropathy is seen in 50 to 60% or even more higher. So if we say neuropathy is the culprit, then why such a small percentage of patients, they suffer from this disease? Now, as I said, because of arteriovenous shunt, the blood supply to the bones gets augmented and more blood reaches the bones and more osteolysis and destruction. So in this setting, any disease which jeopardizes vascular supply to the limbs, so any patient having some degree of peripheral vascular disease paradoxically gets some relief from the Charcot's joint. So this is a very peculiar situation because one disease is protecting from the development of another disease.
Thank you, sir. Now I'll ask Professor Avanikant Misra his experience. He has more than 30 to 35, almost 35 years experience in managing orthopedics problems, and he must be treating this diabetic foot. Let us ask his experience and role of osteophos like bisphosphonates in management of Charcot's foot.
Good evening, all. I think Dr. Madhu and Dr. Venu have nicely presented this Charcot foot. And also, of course, Dr. Patnaik covered this medicine part of diabetics, and then our Bono, and he has given how to prevent ulceration, and that is the actual deeper problem for this foot problem. This is the main reason why the patient comes. And by the time the Charcot's foot develops, and after that only the orthopedicians are required. And now with my experience, what I see, that is very difficult to do bony surgeries in these cases because you don't know what is the this outcome that will be. In normal bone, when you want bone surgeries and you want fusion, when you want to do this exostosis excision, the results are good. But in these cases, the failure are much more, and it becomes very difficult. And that's why in our part, it is this amputation below knee is becoming more common than these things in previously. But now we have also improved, and we are going for these surgeries. And my question to Venu is: yes, is there any non-diabetic Charcot's foods? What they encounter? This is my question. Non-diabetic, and why I'm asking is recently I had a case just in the first stage when I did the debridement. I sent the tissue for biopsy, and the culture became sterile, and the tissue, the histopathology that came as tuberculosis, and started anti-tubercular, and the patient is improving. So in diabetes, always it is not diabetes, sometimes, but the case is diabetic. So what is the opinion I asked from Venu and Dr. Patnaik?
Sure. I think the culprit here is peripheral neuropathy. And peripheral neuropathy was more common due to other pathologies in the past, but now it is predominantly diabetes, as we all know. So, for example, peripheral neuropathy related to other conditions, we include about, I think, our diabetic foot clinic, so-called diabetic foot clinic, is actually peripheral neuropathy clinic. We take all referrals of patients with peripheral neuropathy, not just diabetes. So 17% of our neuropathic foot related presentations are actually non-diabetic. Peripheral neuropathy not due to diabetes. It ranges from, if we have a very few patients of congenital insensitivity to pain, or patients spina bifida, patients with very advanced Charcot-Marie tooth with very marked peripheral neuropathy involvement, and so on. Yeah, that's a very good question. And listening to yourself, Dr. Patnaik, and rest of the colleagues, you have covered so much on the non-surgical side, which is really important to actually make sure that the delegates are fully made aware of. But interestingly, the behavior of bone following reconstruction or any surgical procedures was found to be quite unsatisfactory or different in the past, and particularly when we used internal fixation technique, and no doubt, and the failure rate was very high, and we used to just simply blame Charcot bone and nothing else. But when we looked into the fixation techniques and principles, and in the past, we were applying just the fracture fixation principles. When broken bone, when it is fixed, we use certain type of principles, and those principles were applied for Charcot foot reconstruction as well. But unfortunately, they failed. So we were blaming just simply the bone. Charcot bone doesn't heal, but it does heal. And in fact, to our pleasant surprise, the bone healing rate is much, much better than what we had taught in the past, but it requires different type of fixation principles. So the answer to your question, very important question about neuropathy, if it is if it is the diabetes or neuropathy component of diabetic complication, if one of those is the culprit, we feel that it is the peripheral neuropathy. That is the main culprit. Peripheral neuropathy of any origin can cause Charcot, but those people with diabetes develop additional problems, include predominantly the vasculopathy. I hope I answered your question.
Thank you. Thank you.
Well, thank you. Actually, I had read somewhere that almost more than 50% of patients with diabetic foot, they go into amputation. But you showed such fantastic results. It is quite heartening. There are a few audience questions. I'll request one, Dr. Benu, to answer one question. What is the correlation of Eisenhower staging and surgery for Charcot's joint at present?
Okay, I can do. Shall I take the?
Sure.
We had a very interesting observation. Eisenhower staging was initially introduced to give chronological staging of the disease. Means every Charcot has to go through stage 1, stage 2, and stage 3. So every stage 1 will become stage 3. But since stage 0 was introduced, in fact, we identified that doesn't progress. It doesn't even start. If you treat stage 0 with total contact casting, absolute offloading, now Dr. Madhu Thiruvidala describes about Achilles tendon release, which is currently being evaluated. But whatever you do, as soon as you address the underlying mechanical and biological components, it stops. It doesn't go to stage 1, doesn't go to stage 3 and 4. So yes, intervention during stage 0 outcomes are fantastic. Stage 1 outcomes are very good. But when it becomes to stage 2 or 3, then you're dealing with much greater deformity.
So there is another question from audience. When do you do gastrocnemius recession and when do you triple hemisection?
Okay, Madhu will answer that question. I type and I answer.
Presented that. Madhu is there? Yes.
So gastric recession is purely because if I'm doing surgery in theater as a part of reconstruction, then I tend to do gastrocnemius recession in theater. But if I'm doing in the outpatient department, then I will do hemisection.
So what we do is basically, obviously, for all the such presentations, we do Silver's coil test, which differentiates if it is an isolated gastrocnemius contracture or full heel cord contracture. And of course, in non-neuropathic, non-diabetic presentations, for example, plantar fasciitis, those kind of presentations, you see gastrocnemius contracture a lot more often. It's very rare that we see full heel cord contracture. But interestingly, as Dr. Thiruvidala explained from the pathogenesis and Dr. Patnaik as well, basically this glycosylation and everything related to diabetes seem to affect the bulky tendons a lot more. So most diabetic foot deformities seem to present with whole heel cord contraction rather than isolated tightness of gastrocnemius. But if your clinical examination shows it is predominantly or exclusively tied to gastrocnemius, we feel that we should do only gastroc release, which is what we do. But in our experience, that incidence is very, very low. I hope that answers the question.
Can you elaborate some of medical products used like denosumab and teriparatide and also sometimes calcitonin? All these are being used now more and more. Denosumab has shown promising results. Have you used it?
Our experience is little, and probably you are aware, I'm sure you are aware, Prof. Nirmal, that when you attended our unit and subsequently, a number of these trials were actually done at King's College Hospital as well. And in some of those trials, we had to stop some of those trials. Yeah, the medical treatment is very promising, but it is not as great as we had all previously expected.
Okay, there is one
perhaps,
question.
Dr. Patnaik can elaborate on that. Yes.
Yes.
In fact, I skipped that point because there are trials with most of these bisphosphonates, starting from etidronate to alendronate, pamidronate, and zolendronate, and most of these trials were done with pamidronate. There are, if you see the meta-analysis, there are some benefit, but the benefit is not much to suggest.
No, we don't use them. And
something calcitonin is also not much help. Denosumab, the trials are very few. And you mentioned about parathyroid hormone. Basic problem in Charcot's is osteoclast activation. So we have to tame the osteoclasts. We have to use anti-receptive medicines. Parathyroid hormone is not a good drug for this.
So
yes, drugs.
Good. And Nirmal, I just have want to have a clarification. How many of these cases have peripheral arterial disease associated? Dr. Ben.
Sir, there is also one question. Is there any role for surgery in diabetic foot when the Charcot's disease? Maybe both can be answered by Benu.
Oh, okay. Vascular component, that's a very good question, Dr. Kailash. And again, it's interesting that the incidence of significant vascular compromise is constantly rising among people with Charcot and for people with diabetes as well. I think that reflects that these people are living longer. The people with, many people used to lose their limbs in the past, so vascular compromise was not in the equation. But many people are living longer. Many people are living longer with Charcot as well. Now, the most recent evidence shows the incidence of significant peripheral vascular disease during Charcot significant is 20%. From our experience, from our series, 25% of them had significant peripheral vascular disease that required revascularization, either prior to or immediately after our reconstruction surgery. We have done 157 Charcot foot reconstructions. Many of them are referred from other centers. Many of them were recommended below knee amputation, but we haven't had a limb loss, even a single limb loss as yet. But doesn't mean that it will never happen. But so far, we've been quite fortunate because all of these are thoroughly assessed by the vascular colleagues in the MDT. And if there is any significant far distal vascular compromise as well, they are managed with angioplasty or bypass or hybrid, predominantly angioplasty. They do angioplasty of plantar arch in far distal as well. So that has been our experience. The incidence of peripheral vascular disease in advanced Charcot foot presentations is very high, a lot higher than what we thought. And the second question about Charcot foot reconstruction, surgical reconstruction. Yes, I mean, Dr. Thiruvidula does a lot. We are doing a lot of these reconstructions. And I think, in the coming few years, there will be overwhelming evidence in the literature that is the gold standard. And because these people they live much longer because of the functional limb salvage, means they can weight bear in shoes, or in worst come scenario in braces. And that prolongs their lifespan, and the quality of life is a lot better. And the effect on cardiac, rest of the renal and rest of the organs is a lot better. So, and the myth about the Charcot bones never heal or have poor healing, that is gone now. We have enough evidence. As I said, in about 5 years' time, there will be massive evidence. Already, there's so much evidence. That is my view, and Dr. Thiruvidula might want to add something as well.
My view with the reconstruction is that when you see a patient and you have a deformity and you offer them, you have a choice of an amputation or a reconstruction, which can sometimes be a 2 or 3 surgery and can take up to 6 months to up to 1 year. And often I haven't seen a single person so far who would say they would prefer to go for amputation. They would say, try whatever you can, but save the foot. And we have instances where we've done more than 2 or 3 surgeries and things are not going as we expected. And when I say, I'm sorry, I can't think of anything else to do, now is the time for amputation, they still say, fine, no, leave it alone. They're able to walk, they have a foot to look at, they can live with it. So the patient perception of reconstruction is changing. And the most satisfied people are diabetic people. As you can see, I do pediatrics and I do non-diabetic foot and ankle and foot and ankle. Diabetic foot and ankle patients are most satisfied people. Even if you save the foot and they can stand, doesn't matter how the foot looks, they are the satisfied people. And that's the reason why we do all these complex reconstruction on the patients.
Well, Professor Kadas Mahapatra has the maximum experience of diabetic foot in our state. I request him to have his final comment and any other questions he wants to ask before we wind up. We're already half an hour late.
I'm extremely, delighted to have these 2 beautiful, excellent presentations, very lucid presentations, self-explanatory by Professor Madhu and Professor Benu. And this is coming in a big way, and this is the only game changer. The surgical reconstruction of Charcot Foot is going to be the light of the next. And from this will bring a lot of hope from despair. People will not try to lose their limb. They will try to preserve, as Professor Madhu said, though whatever people are very much excited and to have their limb, and whether it is a 2-stage reconstruction or 3-stage reconstruction, they want to have their limb at least. And that is, and Professor Benu told about also, if you do an amputation, these mortality, 5-year mortality is more than 80%. So therefore, the limb salvage is the talk of the time. And in diabetic foot, we should do whatever possible way to preserve the limb. One question, I want to know, in UK, what is the role of this stem cell therapy? There are so many articles are coming. The mesenchymal stem cells in Charcot Foot are promising, giving good results. Is there any experience of Professor Benu and Professor Madhu?
Okay, we have participated in a trial about 12 years ago, and that showed absolutely no difference. So we discontinued. So it's a bit unfortunate that we keep seeing the same, exactly the same product, the same thing keep coming back again and again. There is no evidence. You see, this is predominantly a mechanical, vascular related problem. It's not just from simple biological stimulation.
Thank you very much. Thank you.
Okay. I want to add one small observation. Is also what Dr. Patnaik said, that we see quite a lot of patients with diabetic related neuropathy, but not Charcot neuropathy. Now this is where I haven't proven it, because in the UK, we see quite a lot of patients of various races. And I can say that the diabetic neuropathy or Charcot neuropathy is a disease of white race. Of all the patients, if you see it, majority of patients are white, some are black. Extremely rarely we see an Asian patient coming with a Charcot midfoot deformity. Now, I don't know why, but that's what it is. So it's very not surprising that you see very minimal midfoot Charcot deformity compared to rest of the peripheral neuropathy. So, but I don't know why this racial discrimination is there, but it is there.
Okay, before we end up, I'll request, before I ask Dr. Basan Behra, our secretary, to say a vote of thanks, I'll ask Sirsendo to say a few lines if he wants. Sirsendo, are you there? Okay, Basan, vote of thanks.
Okay, it is my pride, privilege and honor on my part to give vote of thanks on behalf of Odisha Orthopedic Association to eminent speakers, Dr. Benu and Dr. Madhu. Really, we are thankful to you. You have given time for us and you have so enlightened us with the Charcot joint. Although it is a very rare subject, but it is not uncommon and we learn a lot. So, Dr. Benu, you are associated with the association long time. So, I hope we are having conference in the month of January 2002. And if you are visiting India, I invite you again to come and have some program with us. So I am thankful to the panelists, both Mahapatras, panelist Dr. Kailas, panelist Professor B.B. Misra, Professor Patnaik and Professor Abani Misra for their beautiful discussion. I am thankful to our two Mahapatras, Dr. Nimal Chandra Mahapatra, my friend, and Professor Dr. Kailas Chandra Mahapatra for beautiful moderating the session. I must thank our President IOA, Dr. Shiv Shankar and Dr. Naveen Thakkar, Secretary, for allowing us the IOTV to be telecast in IOTV and OTV, Ortho TV. And we are also thankful to Dr. Ashok and Dr. Huda for allowing us to the program. I am also thankful to ASI Odisha chapter, Chairman Dr. Vikas Ranjan Hota and Dr. S.S. Sutar for associating with our association. And in the last but not least, I am thankful to Dr. Swasat, our OGAT team, who helped us making this program success. I hope that our colleagues must have learned a lot from this discussion and not tried to preserve the foot without going for amputation, but it needs a lot of patience and dedication towards the patient. Thank you very much. Thank you all.
Thank you.
Thank you.
Thank you very much. Thank you.
Thank you, Mr. Sirsendo. I called you, but you were not there. Anyway, thank you very much.
Thank you.
So when I am again inviting you.
Thank you. Yes, certainly.
If you are visiting in January, then please make a want to attend the program.
Absolutely, certainly.
If you're planning, naturally you can come. That will be most pleasant time, you know.
Because it is in Puri. We are holding this conference in the Puri itself.
Thank you very much, Dr. Basanta. Definitely we'll plan. And
Okay.
obviously,
Good night,
good night, everyone.
Good night. Good night.
Take it. Thank you very much. Take care. Bye.
Bye. Bye.
Bye.